Thank you very much, Dr. Sabik. Ladies and gentlemen, I hope you're all friends. I would like to give you some insight into research models, and I think a lot of this has major clinical implication. For I'm also a practical surgeon and see the problems on a daily basis. I won't show you too many flow curves. I will give you some interpretations of flow curves. My disclosure is in here. I have no financial interests. The background for this is that the competitive flow is assumed to occur frequently in coronary surgery. And the problem we know has been for years is that coronary arteries with low-grade stenosis has been grafted too often and too many. Previously, we haven't had the tools to assess this well enough. Previous clinical studies with angiography has shown a better long-term patency when grafts are directed distally to severe stenosis rather than beyond non-significant lesions. However, there is quite limited knowledge of the pathophysiology and biomechanical mechanisms of competitive flow. And we try to give you some ideas about this by this talk. So I think for many years experimental studies has been lacking. Our work has been mainly done in Trondheim. We have a university there with major interest in technology and partly also an ultrasound technology. It's the core laboratory for GE and also for other technology connected to ultrasound and ultrasonic research. And we are quite a large group of people. And for this study, we have had a very important and fruitful collaboration with the Ghent University in Belgium. So the outline for this talk is coronary graft assessment, wall shear stress related to endothelial dysfunction, and experimental research. The basic tool for the clinician now is TTFM, transit time flowmetry, to be used in clinical practice. And there are guidelines for how to assess the flow measurements. However, as stated here, validation of grafts also depends on what we actually expect, particularly from angiography, and also what we can see in the surgical field. So whether we do have guidelines, as seen here, regarding mean graft flow, the diastolic flow, which it should be more than 50, and and the retrograde flow should be small. Pulsatility index should be low, less than 5 with the medicine equipment. But we know from another paper we have made that if you use the transonic, it is normally less than 3. So when you read flow measurement studies, you should have a look at which equipment has been used. So I will make this assessment now because it should be more than, okay? So we know from many studies and from clinical practice that vein grafts do have higher flows, usually than the arterial grafts. And using sequential grafts, we get even better flow. We have looked at this through a study published in 2009, particularly analyzing sequential grafts. And we can see that the more sequential connections we had, the more the flow, both in male and female. And we have moved further to see what role competitive flow has in the porcine model. A paper published also in 2009 in the European Journal. With this study, we wanted to compare competitive flow with stenotic anastomosis. And our research question was that can we detect and discriminate competitive flow and stenotic anastomosis with flowmetry? We used an experimental animal model with 10 pigs. We did op-cab surgery, lima to LAD anastomosis. We assessed the flow with TTFM and epicardial ultrasound with a mini ultrasound probe. This is a setup which is a bit confusing just looking at the picture, but we made flow in different parts of the grafts and native arteries and pulmonary artery. So we ended up making simulations of 4 flow situations as in clinical CABG situations. The baseline was anastomosis with an occluded native LAD without any competitive flow. We had a model with full competitive flow, still a normal anastomosis between the mammary artery and the LAD, assuming a non-significant LAD lesion. And also a partial competitive flow, using a balloon, reducing the flow to 50%, assuming this was a significant LAD lesion. And finally comparing this with a normal anastomosis until we made a distal stenosis in a toe anastomosis with a stitch in every pig, but still an occluded LAD proximally. We assessed the anastomosis with the epicardial ultrasound, and we could easily measure the dimensions with the epicardial ultrasound of the toe of the anastomosis being narrowed. And the mean stenosis of this anastomosis was about 75% luminal stenosis, 50% in diameter reduction. What we found was that the full competitive flow had an impact on all the variables, with reducing mean flow, diastolic filling, and it increased the retrovagal flow as well as the pulsatility index. So this is a very major message. Whereas partial competitive flow also gave reduction of the mean flow and the diastolic flow. However, the retrovagal flow and pulsatility index did not change, but it was definitely sensitive on these parameters. The anastomosis of the toe did, as we know from clinical studies being reported previously, did not actually change anything. We did not get any reduction in flow. You need a stenosis more than 75 to 80% to get an impact on the flow at rest. at rest. So the summary was that the full and partial competitive flow reduced both mean flow and diastolic flow, which is very important. But full flow also increased pulsatility index and ventricular flow. Increased it had a negative factor, we can say, on the pulsatility index and ventricular flow. However, the anastomotic stenosis did not change. So this means if we have a problem with anastomosis, we should definitely think about competitive flow if we see major changes compared to what we expect from the flow measurement. Not only think there is a problem with anastomosis, it could be good, unless it's very severely stenotic. So competitive flow matters intraoperatively. We do have a tool today also by using epicardial imaging. We can look at the native LAD and assess whether there are stenosis proximally, as shown here. We can also use epicardial imaging to assess the anastomosis, seen here with the Lima to LAD, LAD here, distal LAD, proximal LAD. And when you see an anastomosis like this, you can feel quite confident as a surgeon that this is a perfect anastomosis. The good dimensions, there is no turbulence except from what you would expect from the ultrasound technology. This is a very important tool. So by this method, you can already say that there is no stenosis in the toe of the anastomosis. So that factor is eliminated by this method. So TTFM and epicardial ultrasound give instant patency assessment of grafts. But we have to move this further because competitive flow is supposed to be a determinant of long-term graft patency. And why? This is our next question. There's a phenomenon called the string phenomenon, which is seen in arterial grafts, in particular the Lima. If there is a problem following grafting, and can be seen sometimes at follow-up angiography. So the question is the string phenomenon of arterial grafts related to competitive flow, which a lot of surgeons and cardiologists believe? We asked what impact has competitive flow within grafts and tried to investigate this by looking at the wall shear stress, and presented this in cardiovascular research in December 2010 in collaboration with Ghent University. Wall shear stress has become more interesting lately because we think it has a major influence on the endothelium. And the endothelium is like an organ with hormonal and biochemical function. And if there is a laminar flow, it stimulates the endothelium. If there is turbulent flow, there is low shear stress, and the endothelium is damaged. So we know that endothelium is a very highly dynamic cell layer with a lot of physiological functions. And the wall shear stress is a sort of a regulator of the endothelial function, which has been published years ago. What we believe is that a high wall shear stress is protective whilst a low and disturbed oscillatory wall shear stress promotes endothelial dysfunction and, by time, intimal hyperplasia and atherosclerosis. We used a pig model here as well. What we did was making a cast out of the anastomosis, of the Lima to LED anastomosis. We did a micro-CT of the same. We removed some of the small branches. We left some of the large branches to simplify the study, but still we didn't want to remove all of them to make it too unphysiological. Further, we made a computer fluid dynamic model and could do more assessments, mathematical assessment, ending up with an image like this. It's difficult to interpret, but you do get numbers by wall shear stress units, and you can assess what's going on by this numeric table from the colors. So you see there are differences through the cycle. What actually happened is that we simulated the same competitive flow situations, no competitive flow, reduced competitive flow, or partial competitive flow, and high or full competitive flow, also in this study. There are a high scale wall shear stress system, but that's confusing because everything is blue. Looking at the low wall shear stress scale, we can discriminate between the different situations, showing that the full competitive flow had very low wall shear stress, which is bad for the vessel. It's bad for the endothelium. Whilst the partial competitive flow wasn't that bad, it was much better, and no competitive flow had a much higher wall shear stress, which is good. So what's bad is the full competitive flow. We can also measure the oscillatory shear stress, which was also bad in the full competitive flow. So, concluding, TTFM cannot detect failures in anastomosis unless hemodynamic is significant. However, anastomotic errors can be detected by epicardial ultrasound. Competitive flow influences the TTFM early and substantially, which has to be remembered in clinical practice. And unfavorable wall shear stress seen during high competitive flow may cause damaging effects on the endothelium, inducing endothelial dysfunction. And competitive flow may probably cause Lima narrowing and may be the reason for the string phenomenon, and further reduce long-term patency of arterial bypass grafts. Thank you.